Welcome to Step Up with DL Walker. At any time during our live vidcast premiere, you can ask questions of myself or our guests by typing your question in the box called Top Chat, located in the right-hand corner of your screen. If you're watching a recording and have a question, just type your questions in the comments box below, and we'll be sure to respond. At any time, check out the information box because it contains contact information and special offers from DL and our guests. That's located underneath this video. Enjoy the vidcast, and if you find this information helpful, please give it a like and share it with anyone whom you feel may benefit. Thanks so much for watching, stepping up for your health, and please do be in touch. Dr. Lila Bartkowski-Abbate is the director and owner of New Dimensions Physical Therapy in Roslyn, New York, and she is a graduate of Truro College with bachelor's and master's, as well as a doctor of physical therapy. Currently, she's pursuing her PhD at Nova Southwestern University in Florida and plans to conduct research in women and men's pelvic pain. She has been board certified as a specialist in orthopedics and women's health with the American Physical Therapy Association. She teaches full-time at Truro College for physical therapy, as well as classes in biomechanical approach to orthopedic dysfunction, therapeutic exercise, massage, and soft tissue. She is currently on faculty with the Herman and Wallace Pelvic Rehabilitation Institute, teaching pelvic physical therapy nationally and internationally, and certified as a pelvic floor practitioner. She is a member of the American Physical Therapy Association, the American Urogynecology Association, the International Pelvic Pain Society, as well as the National Vulvodynia Association. So welcome, Lila. Thank you so much for being here. And I had a couple of people reach out to ask some questions for you about continence. And this is an issue that I personally saw you about, as well as some of my friends and family members. And it seems to be, something that happens with age, and it's kind of embarrassing. And so many people don't know that there is help out there for them. So tell me a little bit about what you do in your practice and how it's helpful.
Okay, so as you know, I'm a physical therapist and I'm treating patients who have orthopedic issues and then pelvic floor issues. And the reason that I do a little bit of both is because when you're looking at the pelvis, if someone has like an orthopedic injury, they have like a slip and fall that they don't think is anything that's contributing to like a bladder issue, they trip up a step or trip down a step. And so then an ilium, the bone here, can like upglide, and then that puts the muscles on this bit of a slack. And so then the muscles become a bit inefficient. And so people aren't thinking about something like their back pain being a contributing factor to maybe a bladder issue. But that's kind of what I'm looking at. I'm looking at the whole entire pelvis as a whole, making sure all the bones move correctly. And then from there, then I'm doing an internal assessment of the pelvic floor muscles. And I'm just kind of using like the little muscles here as a little demo. And then I'm going to go in and I'm going to do an assessment, and I'm going to ask the patient to contract and relax and bear down, like can their muscles function appropriately? And so I equate it to almost like a bicep, right? This would be a resting normal pelvic floor tension. Can you squeeze? And I assess squeezing. Can you relax? And then can you bear down? And so the muscles are supposed to do all these functional activities, and that's kind of what we're checking.
So aside from like a misalignment, and anybody who knows my work, I'm all about alignment. I always say that alignment dictates function, frequency, and flow. And so what other things can contribute to continence issues, and why pregnancy or postpartum in particular?
Well, pregnancy is a little the weight, right? So when you're having a growing uterus coming into the area, so that can create more weight, and what will stress a muscle becomes much more apparent as we gain weight. And so we can talk about that relating to pregnancy. We can talk about that relating to obesity. There's studies that show even if women lose 10 or 15 pounds, their incontinence greatly improves. And the other thing that changes with pregnancy is center of mass. So just like you on that whole posture thing, we kind of look at alignment, we look at shoulder, how that relates to hip, how that relates to femur. And as we check all of that, as you're pregnant, your pelvis is going to shift and change. And we gain weight in our back, like that muffin top on pants. We gain the weight in the back to kind of counteract the weight gain for pregnancy. The body's amazing that it does that. And so what happens is it's shifting the pelvis. And then once the woman is postpartum, people don't take time to retrain themselves.
Exactly.
And so that's kind of where they can come and see us. And sometimes just a few visits and we can get a super quick response, because if they have too much weight bearing through the pubic bone and not through the greater trochanter, which would be here in the femur, that's the midline, once that we can correct that little bit of shift and change, sometimes their incontinence can just improve.
Right. Yeah. I noticed that as well. You know, like you said, when we, you know, just like any other orthopedic condition, is that it becomes an unconscious learned pattern. And when you've had changes to your body that have taken place over 40 weeks, and once that, you know, quickly, you know, you have an offset very, very quickly, your body doesn't remember how to go back to where it was, and you're just existing as if you were still carrying that child or two children.
Right. And the other thing that is not even mentioned to women, which is super apparent, are the changes in the ribs.
Yeah.
So as the uterus is growing and as the baby's growing, the organs have to shift up and shift laterally. And the woman can change bra size. So we can go from, we'll just take an example, a 34B, and a woman can become a 40D.
Wow.
And as you know, breast tissue has to engorge, fine.
Right.
But hip shift, we're not really thinking about. And so when the body goes back down, the uterus goes into its space, the organs are starting to shift. A lot of times the ribs don't change.
Right.
And a lot of women are not a 34 anymore. Now they're a 36. They may not be that 40.
Right.
But that change in the rib shifts can change the weight distribution and also the way the dynamic of the pelvis moves. And so another reason to come into PT is just to get your ribs worked on.
I know.
And people will say, you know, you fixed my ribs and that was amazing, right?
Right. And you know what's really cool also, and I feel that, you know, there are 4 places as a PT that I feel are the most undertreated. One is the foot, which my specialty. The second is the pelvis. The third is the rib cage. And the fourth is the cranium.
Oh my goodness, we're the same people.
Yes, like mines. Because the rib cage is, again, most people don't realize how important the rib cage is and how things change when you are, again, pregnant or with weight change. So we've kind of determined that some of the things so far that we could do to help would be, 1, improve alignment.
Right.
2 would be decrease abdominal weight or weight in the trunk in particular. What else are things that people can do to take control of their continence?
Believe it or not, I think that we have to look at overall what you're drinking. Bladder irritants, and I know we've talked a lot about posture and strengthening the back, even would be like a next orthopedic thing that I would mention. But if I'm going to talk about continence in general, there's three evidence-based things that are bladder irritants. We have carbonated beverages, we have caffeine, and we have alcohol. So those are the 3. Right?
Which is the majority of Americans' diet.
I know. But sometimes we just have to look at the bladder diary quickly and say, why is something that was fine in the winter suddenly is changing in the summer?
That's interesting.
Then you look at something like Crystal Light. A lot of people drink Crystal Light. You would never think. It's a citric and it has aspartame. So 2 things, right? So citric is also a bladder irritant, not peer-reviewed, not evidence-based, but definitely on the list of bladder irritation. And then you add that with aspartame, which also becomes a bladder and a bowel irritant. And so people don't even think that it's an irritating factor, but it can be.
Yeah.
We're always adding, water to our, lemon to our drinks, which is great. But if you have a lot of leakage to begin with, that can kind of throw you over the edge.
Right. What about because you mentioned lemon, for example, but what about like acidity and alkalinity? People sometimes like they have these waters now that are more alkaline. Is there anything associated with that?
Well, they just say acidity in general.
Okay.
So that's usually a bladder irritant. And yeah, there's very minimal looking at, water acid base balance, but people who drink maybe more Poland Spring that has a little bit more of an alkaline to it versus some other types of water. You just have to figure out kind of what you're drinking if you're thinking that's an irritant to you. And
then what about timing? Like, is it more about what you drink than rather when? Because
I guess the quick answer would be you have to look at your diary and write things down, and then you're looking at when you're leaking or when you have a lot of urgency, and is there a correlation? So we always have our patients writing down the time of day that they took in whatever, and then how their symptoms kind of lined up. So if I'm going to be going for a run and I have an espresso inside my coffee, I drink that, I urinate before I go, and then while I'm running, I have a huge amount of urgency. Can I contribute that to the espresso and coffee that I just had? So the answer is probably, right?
Right.
And a lot of people during the day are not always drinking as much as they could or should. When they get home at night, then they realize how thirsty they are, and then they're drinking all night.
Right.
So then if they do that, and then they're waking up in the middle of the night to go to the bathroom, which is called Nocturia, that's the medical term for waking up in the middle of the night. So then you're saying, are you like heavy, water loading or liquid loading at night? And that's making you wake up to go to the bathroom in the middle of the night.
Right. So is there an association between nocturia or urgency and continence? And yeah.
So the quick answer is yes.
Mm-hmm.
A lot of people tell me, I don't have a problem during the day. My problem's only at night. I'm here to fix my night problem. For the most part, I'm going to tell them that's probably incorrect. It's only because you're awake and you can easily go to the bathroom, so you don't think that you have a daytime problem. If you're looking at the overall picture and you're seeing that you have your bladder and your bladder should fill. So when you think about normals, I'm just going to give you a little bit of normal. Normal would be that you urinate between 5 and 7 times in a day.
Okay.
Which means I have one full bladder that makes me urinate once every 3 to 4 hours.
Okay.
The amount that's supposed to be in your bladder is supposed to be 400 to 600 cc's, which means 21 to 24 ounces.
Okay.
I'm looking at my bottle here, that's at least, and I don't mean to publicize someone's seltzer type, but it's this big of a bottle or more.
Wow.
And so a lot of people are what's called jicking it, just in case peeing. And Kathy Wallace and Holly Herman kind of came up with that term, that we seem to be going to the bathroom just because it's there or just because it's convenient. And people are not truly filling up their bladder to the top. So when you're doing that behavior during the day, there's no way that your bladder knows the difference between daytime and nighttime, and it doesn't know not to wake you up at night.
Interesting.
So until you train it to fill during the day, and then you go to sleep, your kidneys slow down, you're in a deep REM, your body does not produce the amount of liquid that it normally does during the daytime, and you can typically fully sleep through the night.
So if you mentioned something interesting too about REM sleeping. Right. So if people are not in REM, does that make them more
urinate more?
Yeah.
Yeah. Vasopressin is the hormone that's produced when you're in a REM sleep, and that slows your kidneys down and is telling your kidneys to pump less, to filter at a slower rate. And when patients aren't sleeping in a good amount of REM, their cat's waking them up, their dog's waking them up, they're estrogen deprived and they're awake. So then they have to kind of work on how do they get themselves to sleep better. You know, a nice cool environment, things like that. I mean, I'm not a sleep specialist, but that's kind of the idea. And from there, again, you know, having an improved sleep and then also managing your bladder during the day, they kind of go together.
Interesting. Now I'm going to bring up something very personal is I had a diagnosis of severe anemia, and I, you know, between having my daughter 12 years ago, being pregnant, which also changes your bladder, does it not? When you're pregnant?
Right, it can. And it's the idea of bladder retraining to get you back to what your pre-change was. Like anyone can have a change. It doesn't have to be pregnancy, it could be a surgery.
Right.
Could be, you know, an emotional stress. It could be COVID, right? Like a pandemic can cause all these emotional stressors. And so then you're trying to think of when was the last time that your bladder was normal for you?
Yeah.
And that's what you're trying to get back. And so when you have a little baby and you're up all around the clock, you usually, while I'm up, let me go to the bathroom.
Yeah.
And then the baby's sleeping and then you're up going to the bathroom.
Right,
So
right.
It's almost like we have to teach our female patients to not allow the bladder to rule our lives. If you really feel like you just went an hour ago and you know that you really didn't have an espresso, a coffee, and a bottle of water, you probably don't have to go. And then you measure your urine, you know, and you're kind of getting an idea, all right, I have this type of urge, my bladder should not be full, I'm gonna go back to sleep. I'm not gonna let my bladder and you have to sleep through that period.
Interesting. Well, and going back to my own experience, so very recently, I've been starting to be able to sleep through the night. And I either attribute it to one of two things. Either one, because I had been doing intermittent fasting. And the other thing that changed for me was I had iron infusions for my anemia. And I do feel that I'm dreaming more and experiencing more of that REM sleep. And for the first time in essentially, 12 and a half years, I've been able to sleep through the night without having to get up. And it has changed my life.
Yeah, and the thing is that a lot of people don't realize that there's underlying medical conditions that can leave you sleepless, right? And it's almost like people are sleep deprived all day long, which is a whole other story and a whole other problem. But a lot of people don't feel well because they're not sleeping. So thank goodness you were able to solve your issue and see what a difference that is for you. Right?
Yeah, I mean, there were times, I think 3 times in a night I would be getting up. And now, like I said, I can sleep through the night without having to get up once. And it's incredible. Absolutely incredible. Because sometimes when you get up, then you can't get back to sleep.
Yeah.
Which is also very frustrating.
Right. And some of the patients who are waking up in the middle of the night because their bladder is waking them up, this is something that can easily be fixed. You can remedy this in 2 to 3 months, and it can bring your whole life back. And if this was you and it was your bladder, you had 12 and a half years of not sleeping well.
Right.
And then you can remedy something in a short amount of time, because the bladder is the only organ that seems to be poorly trained and then retrained. So we can't talk to our liver or our pancreas, right?
Right. Because it's a muscle that we have, volitional control over, at least we used to. So, when we're losing control, so now we talked about retraining the bladder, quality of sleep, obviously things that we can change in our diet, particularly the liquid diet. Is there anything as far as food is concerned?
Well, they talk about spicy food, tomatoes, and chocolate. Not on the evidence-based list, but definitely on that list that seems to be a bladder irritant. So, when you're thinking about eating different types of spicy foods, that could definitely be bothersome.
Now, what about if people have, some people have a history of UTIs, urinary tract infections or kidney infections? How will that affect continence?
So as we age, the urethra itself starts to lose estrogen within it, and the plumpness of the urethra starts to degrade. And so that plumpness gives it tone and allows for continence. And then once it starts to degrade, it becomes like almost like an absorbable barrier where bad things will travel from the vaginal vault through the urethra into the bladder and give women UTIs. And that's just because of the changes in estrogen.
And obviously that's something that as we get older, we can't change. Is there anything else that we can do to offset that? Or is that something we just have to put on, okay, can't control, and let's focus on the things that we can control?
Yeah, so it's a little bit of both. So it depends upon your past medical history and what you're allowed to do and what you're allowed to take as far as prescription medication goes. I sometimes do send a lot of my patients back to the physician that their vaginal muscles and their vaginal vault look atrophied. Mm-hmm. As we are in our reproductive years, our vaginal vault is like 21 to 24 layers of thickness. And as we degrade and age and lose estrogen, it can become very thin, 2 to 3 layers.
Wow.
And then nerves will become very superficial. Women can get symptoms of burning, itching, things that are not infection related, but are atrophy related. So sometimes topical estrogen will help patients. Even just lubricating, we have like over-the-counter things called Replens, which is a vaginal lubricant and moisturizer that women can use topically. They put that in at night before they go to sleep, and then sometimes that just helps some of the tissue. And I have had patients who have had breast cancer that are followed by their breast surgeon, and they're able to use sometimes topical estrase cream sparingly.
Right, of course.
Yeah, and that can help a little bit. So every situation is slightly different. It depends upon the past medical history, and then we as physical therapists can make suggestions based on the tissue, and then they are speaking with their physicians to see if that's a good fit for them.
Right. And you go back to physical therapy, and I think it's important to mention that there's a specialty or within physical therapy with the pelvic floor, right?
Right. So you're an orthopedic therapist. Mm-hmm. I'm an orthopedic therapist, but I have specialized training and I do internal work.
Right.
And I do internal vaginal assessment, internal rectal assessment, and that's my other subspecialty.
Right.
And so if you need to find, need to find someone, that's what you're looking for, someone that does internal vaginal and rectal pelvic health assessment.
Very good. So
even contracting the muscles bring in blood flow, and that blood flow can just help rejuvenate a bit of the vaginal pelvic floor without hormones or without moisturizers.
Right. Yeah, that's a good point. It's really good.
Yeah, sometimes just Kegling helps.
Right. So that's what a question did come in about that. That doing Kegels might not be the best solution.
Right.
And I think you've answered that already. It really, you have to look at the whole picture. Yeah. And
Yeah. And so the thing is that we don't know where your muscles are. We're making you're coming in with your complaints. We're surmising, making a story, a medical hypothesis. Mm-hmm. Based on urinary frequency urgency, and maybe you're in your 60s. I don't know if I'm guessing weakness. I'm guessing maybe sometimes your muscles are a little bit too tight. And so people will say, well, I have leakage, but how could I be tight? And the reason is because the muscles are supposed to be sitting here. And when you're moving from sit to stand, your muscles are supposed to kind of turn on and contract for you and move.
Right.
And protect you from the urine coming out. So when I have this picture here, if you can see that, here's our bladder, muscles are intact. There's a pressure coming from above, and this person can stay continent. Here, there's a pressure from above, and this person is incontinent, and the muscles are not able to contract well, and that could be because they're tight. Mm-hmm. So when they go to sit and to stand, their muscles can't engage. They can't do anything to help them because they're already living in that shortened position. And so that's what we're doing. We're trying to assess, does the patient need strengthening or do they need lengthening?
Right.
And so as we age, we can use lengthening. If we're a high-end athlete and we are young and we're in our 20s and we're on like a D1 varsity team and we're training 35 to 40 hours a week, we're working on our core all the time. You can almost bet that these women have leakage issues because they're tight.
Right.
And then that's kind of like the change. Like we've kind of really thought about, wow, muscles must be weak. They must be weak, but
Right.
muscles can be tight. And sometimes I'm doing a lot of stretching. So just like you would have a tight muscle in your neck, we're going in vaginally and we're going in and stretching the muscles around the urethra. And we're trying to help those muscles lengthen again.
Right.
So that's kind of like a different way to look at leakage.
Absolutely. And that happened to be my problem, per your assessment. So, and that, yeah, it kind of fit the bill, because here, again, I was that athlete. And, postpartum, I was doing, the activities that I thought were helpful. Certainly Pilates was one of them. And I understand too, that there's and this would go with the whole ribcage issue, but can you talk about the connection between the diaphragm and the pelvic floor?
Sure. So initially, when we think about the pelvic floor, we're only thinking about the pelvis, and we don't really think about how it relates to the top.
Right.
But the diaphragm and the pelvic floor have a relationship. So as you inhale, the pelvic floor will rise. As you exhale, the pelvic floor will drop. And so a lot of people are worried about like looking skinny, being up and in.
Right.
That whole like idea of maybe, and I'm over exemplifying Pilates in this manner.
Of course.
Just that tightness and having good core strength can make people too tight.
Yeah.
And so then their pelvic floor is elevated.
Mm.
So we have to think about relaxing and fully breathing. And we teach our patients diaphragmatic breathing. So sometimes we get into poor breathing patterns. It can happen from an injury nonetheless, but you put your hand on your upper chest, you put your hands kind of like underneath your ribs on your abdomen, and you're taking, if I just move my camera here, if I take a full deep breath, I'm really looking for my bottom hand to move. I don't want my top hand to move.
Right.
And so then as Deb, as you know, as being a physical therapist, we treat a lot of patients who do what's called apical breathing, which is this upper breathing. They got into using their muscles of their neck to help them. That could happen when they maybe have a cardiac surgery. They just have like an injury even to their ribs. And so people get into these poor breathing patterns, and to understand that the diaphragm and the pelvic floor have this nice, comfortable relationship, that really helps people relax their pelvic floor. Right. Another thing, when you think about it, I've set myself up here with a chair.
Yeah.
Is that a lot of people struggle to get in and out of a chair.
Yes.
So as we age and our patient is sitting in the chair, and you see them go up there, they're pushing to get up, they wind up using their diaphragm to stabilize their spine. So when you think about those posterior slips of the diaphragm, how that relates to the low back muscles of the psoas, they use their diaphragm and their breath to hold their breath right out of a chair. And then what does that do? It creates leakage.
So that's one of the instances that people will experience leakage is getting up, or anytime they're straining. So obviously, talk about like coughing, laughing, those kinds of things. Would that be a similar example?
So it's hard to say, right? Coughing, laughing, sneezing, that could easily be this picture, that could easily be weakness, right? But what happens is sometimes when we have our patient complaining of sit to stand complaints, and they only leak with that and running, you're wondering, what are they doing with their breath? So do they wind up in certain sections? Are their hips too tight? The hip muscles too tight? Because when you move from sit to stand, your obturator has to fire up, parts of your pelvic floor have to fire up. And so then the question kind of becomes complicated. It's not so easy.
Right. Yeah. So, and obviously that's where a good history comes into play, because then you can, and that's what you and I both do, and very good PTs will do. It's like, okay, well, will this correlate with that?
Right.
What correlates, what doesn't correlate, and it gives you what we call a clinical picture to really kind of hone down, because, you know, I've always said this too, is that any problem that we're having, there's probably 100 different things that you can do to help it. No. And 100 things that you could do to hurt it. And the key is really figuring out what are the, you know, the causes for your particular issue. And they're not always going to be the same. That's why cookie cutter programs are, you know, not appropriate for everybody.
Right. And telehealth has been fabulous in this year that we've been in somewhat of a lockdown.
Right.
But nothing takes the place of a physical exam. So right. we can surmise, we can hear your story, we can come up with, you know, guesses of what we're supposed to do. But physical therapy overall is like an in-person type of medium in a way, especially when it comes to muscles of the pelvis. You can have in that one compartment, on the top being tight, on the bottom being loose. It's amazing what the body will do to compensate, to create what we call homeostasis. The body's looking to be in balance. Right. And you can have urinary leakage on the top, and you can have no sexual dysfunction and no other issues. And so then it's, you know, like the muscles can be tight and people can still leak. So it's
right. So in general, so that's the important thing too, to figure out whether you are, you know, you have, you know, what you need to work on, whether it is to restore balance.
Yeah.
Right. So somebody who is maybe too tight, they would benefit more from release type of work and that kind of thing. Right. And then the people who have weakness. But again, I think it's really important to talk about, and I'm going to get into it in a second, about alignment, particularly, again, anybody who has a history of falling on their butt. You know, that is certainly, and who hasn't in their lifetime, even if it's something that's happened long ago.
Right.
So, and in particular, a structure that you and I and you especially, let's talk about the coccyx.
Okay.
So tell me about, you know, how the coccyx relates. That's the tailbone. Right. It's the base of the spine. And
all right, so you have your two ilia. This is L5, sacrum, and at the base we have the coccyx.
Right.
Okay. And so the coccyx has a muscle that attaches to the body, and it goes to a little bony landmark called the ischial spine. Mm-hmm. It attaches this way. And the coccygeus, that's the muscle, actually is a SI stabilizer. Okay. And so people don't realize that almost the coccyx bone, if I'm a bone, and my arms are the coccygeus muscles, it almost acts like a flag or a mast on a boat, like it's stabilizing this top portion. Mm-hmm. And so a lot of people who wind up getting into some coccyx issues can sometimes have a long-standing history of back pain, mm-hmm. or concurrent low back pain.
Right.
So a lot of times I've written a course called Coccygeneal Painful Sitting, and I'm always looking at the way the mechanics move on the ilia and the sacrum, because this bone is only 10% weight bearing. Mm-hmm. Like we never think about our fibula in our leg, you know, right. It's kind of on the side. We don't go, oh yeah, hey, my fibula hurts today, right? 10% right. weight bearing bone. Same thing here with the coccyx. So the mechanics have to really be off with the ischial tuberosities here and or the sacrum to have this bone start to be painful. Right. And so then sometimes we're really looking above and below. What are the ribs doing? What are the femurs and the hips and the knees doing? Like why all of a sudden now is this a problem?
Mm. And is it usually due to trauma, or is it typically over time?
So the research shows that it's like varied. You can have someone who out of nowhere wakes up one morning and boom, has coccydynia. And then you have the people who have it kind of coming over time. And then you have the person, boom, trauma fall. Traumas are the easiest to treat, which I hate to say, but they are. We have a mechanism of injury. We kind of understand what happened in that injury, and we can correct that. Right. So the things that we talk about with coccyx pain is that if you have a little bit of coccyx pain, you have to go get treated right away. The longer coccyx pain is standing, the harder it is to get rid of it. they talk about coccyx pain of 6 months and younger is easily treatable, whereas when it becomes chronic in the 6-month state and older, much more difficult to treat.
Why is that?
I think because the nerves wind up becoming chronically irritated, and it's hard to then treat a biomechanical bone problem with a nerve injury.
Right. So another question that I have, I was taught to, when you're sitting, right?
Yeah.
That you should kind of sit over your vaginal opening.
Oh, forward.
Yeah, bear weight over, directly over your vaginal opening.
Oh, okay.
Yeah, and I've tried that in class and doing a Kegel from that position versus, like a slouched sitting, or how people typically sit in their cars or in chairs. And I was wondering, your thoughts on that.
Okay, so I can make a comment on the vaginal sitting.
Yeah.
So you're really tilting your pelvis very far forward when you're doing it. So if that's giving you back pain, that's something to correct, but the weight bearing should really be on ischial tubes and in more of a neutral spine. Okay, so that's one statement. Now, when women have urinary incontinence, super, super interesting, is that we lose the ability to fire the superficial muscles. In research, they've shown that in standing up tall posturing, women who are continent can engage everything, superficial and deep, easily. As soon as you become urinary incontinent, the first layer, the superficial layer, shuts off. So a way to engage that is your position of forward sitting. So we teach our patients, I'm going to move my camera,
right,
to sit and lean your elbows on your knees, and then to do a Kegel from this position.
Right.
Then you are changing your pressure, you're changing your weight bearing, and you are then looking to engage the first layer muscles. So when the patients are very weak and it's in the beginning and we know weakness is the problem, we have our patients do forward leaning when they are looking to engage first layer superficial muscles. And so then if you and I just sit up tall now and we engage our muscles, easy. Then if we lean forward, it's actually even easier to do that. And when we move to slump, terrible. Slumped posture does not engage the pelvic floor well at all. So research shows that tall sitting and then extra tall sitting really helps engage the superficial layer.
Excellent. And yeah, I could definitely see that, because you're creating like a stimulation almost.
Yeah.
So somebody also asked about a vibrational plate. 4D vibrational plate. Could you talk about that?
Vibration is just sometimes good overall. It kind of stimulates the muscles. It almost is like a neuro type of stimulation that kind of helps. If patients sit on it, if they have it in their gym and they sit on it and they can do some Kegels, that could be an added little bonus. You can stand on it as well and try. But remember, lying down is the easiest way to engage your pelvic floor, followed by sitting, followed by standing, and then functional activities are the most difficult. Standing, squatting, walking up downstairs, those are really difficult to engage your pelvic floor in. So if the person's going to be using a vibrational plate and they have a hard time engaging, I would tell them if they could sit on the plate, that would be a lot easier for them to engage their pelvic floor. Standing is kind of difficult. You have to have a good amount of awareness.
Right. And again, some people will have continence in sitting, but not standing.
Yeah.
Like when they sneeze, for example, or cough.
Yeah, and it can be different because in standing, maybe they can engage their diaphragm a little bit more. And so we teach patients something called the knack. And the knack is like a trick, a little tool. And you are then trying to, if you know that sneeze is coming on or you know that cough is coming on, you try to Kegel before and then you sneeze, right? And so we train our patients to do that because we're trying to reinstate normal function. At one point, the body used to do that and it lost that ability. And so
Right.
we're teaching our patients to re-engage, and then eventually we're hoping it comes on within the normal time frame. Your abdominals and your pelvic floor are supposed to turn on before you move an arm or a limb, right? And so
Right.
that pressure, that downward pressure, is also supposed to be like a pre-activation. Those muscles are supposed to come on before in order to take this assault of the system, which is a sneeze, a cough, or a laugh, right? And then they
Right.
wind up leaking. So you're staying continent here, and then here you can't. So here we teach our patients, do the neck, squeeze those muscles, because here you're failing,
Right.
right?
Yeah, absolutely. Now, why is it easier to engage the pelvic floor in lying down?
Because it's gravity eliminated.
Okay.
And so, just like we would test someone's, shoulder strength, it's hard to do it in a sitting position, but in lying down, it's a lot easier for people to move their arms. Same thing with the pelvic floor. You're not in line. If I just kind of get my pelvis here, gravity is in line. It's hard to fight against gravity.
Uh-huh.
When you're lying down, it's not in line anymore.
Okay. Got it. Great. So one last thing before we wrap up. You know what? If you had to give 3 best pieces of advice for somebody dealing with this problem, I'm going to answer number one. Number one is go to a PT who specializes in pelvic floor. That's number one. But what would be 3 other things that you could recommend in the meantime?
So the complaint is urinary incontinence.
Yeah.
Right? Okay. So first I would be cognizant of what you're intaking.
Mm-hmm.
Seeing if you have a lot of bladder irritants, which will make your problem a lot worse. Assess your core. Realize how much core strength do you have, and do you think that you are then putting too much pressure on your pelvic floor because you don't have enough strength? And then potentially exercising your pelvic floor, which would be nice to have an assessment by a physical therapist, but there's no harm in trying 20 Kegels in a day.
Right.
If people are a little tight, it's typically not throwing them into more tightness. It could just be like a little blood flow into the area. It's probably not changing a huge tightness problem, but it could actually change a weakness problem. And so the research shows that 24 Kegels a day are the minimum for people to maintain continence. And if you're going to look for changes, you're really not going to see them for 6 weeks.
Okay. And there's a couple other things. Tell me about the association between shush and pelvic floor contraction.
So the shush sound actually turns on more of the urethral muscles than just a basic Kegel would alone. So if we're sitting here together, you and I say, okay, Kegel, because no one knows what you're doing, right? You can Kegel, you can drive, Kegel at the lights, Kegel doing commercials on TV. Right. When you add the shush sound, shh, you're really turning on your transverse abdominis. So I'm going to move my camera. Mm-hmm. If we find hip bones, we move an inch in and an inch down. And in that position, as soon as you make the shush sound, shh, shh, you can feel it comes on like a little trampoline. The transverse abdominis engages a bit more. So here's my bones. I went in an inch. I went inferior an inch as well. And it's the most thin area where we can feel the transverse abdominis the best. And so that shush sound helps the transversus come on and helps the bladder, the urethral muscles also engage the best. So you can't be kind of weak about it. You can't go shh. Like that's really not going to help. You have to be a little forceful, add a little gusto, and go shh. So that you can't do probably in a room with friends. You probably need to do that on your own, but that really helps.
Right. Like, yeah, I am being quiet. Yeah, I don't need to shush. Lastly, one of the things that I noticed is with menstruation, I use a Diva cup.
Right.
And I had found that, or I had noticed that I would have felt like I had better control with that. Could you talk about how that might be possible?
Sure. So when we look at the pelvic floor, and I don't know if you can kind of see all the organs. So we have the bladder, we have the uterus, we have the rectum. And if you're putting that diva cup up at the uterus, it's actually giving support.
Ah,
And so what happens is that it's tucked up around the uterus in order to then catch the menstruation, the blood, but it also gives a connective tissue support. And then sometimes we'll even change the position of the urethra and leakage will improve.
interesting.
And so then a lot of women sometimes go to a urogynecologist, or some gynecologists will also do this, but a urogynecologist is the specialist that then helps with organ support for women. And then there's pessaries. So the pessaries are like a little plastic, like the old-fashioned diaphragm that kind of pops in and pops into place. And it's easily taken out.
Right.
Patients can get their own pessary. If you have a ring one, you can actually leave it in during intercourse. Sometimes it actually gives a little bit more support to the pelvis itself, and women have more pleasure with the diaphragm, with the pessary being in. And then if you have a lot of prolapse where a lot of the organs are descending more than it should, there's different sizes, different cubes. One's a more posterior wall support, one's more of an anterior wall support. And that's a more conservative way to stabilize and keep the organs up while you do pelvic floor strengthening. Pelvic floor strengthening has shown to decrease prolapse by 1 full grade.
That's fantastic.
So if the organs are coming like at the introitus, that vaginal opening, and you're starting to see some things kind of come down, pelvic floor strengthening can improve that by 1 grade.
Wow. So how do you get fitted for that pessary that you're talking about?
Yeah, you have to go to a urogynecologist typically. Some gynecologists do have pessary fitting, so it depends upon the doctor. They may or may not have like the breadth of them, the depth of them. There's like 20 different types. There's 4 or 5 different sizes per pessary. And urogynes are typically doing that all the time. So
that would be another specialty to look into, as well as pelvic floor physical therapy.
Right. Urogynecologists are surgeons that do pelvic floor support and pelvic floor surgical rehab. They're doing the surgical medical side. And then pessaries are conservative pre-step to doing surgery.
For prolapse.
For prolapse, yeah.
Right. What grade of prolapse requires surgery?
Typically when the organs are out of the body, then they're definitely a candidate. But people can have severe back pain just with having a grade. There's 4 grades, 1, 2, 3, 4. 1 is minor, you can barely see it. 2 is at the opening. 3 slides a little past the opening, and 4 is out.
Wow.
Right? And so typically we can't help a 4 that has too much lax and connective tissue.
Sure.
The muscles are beyond, they can actually be strong, but the connective tissue is too weak.
Yeah.
And grade 3, we can at least make a change to come into the body, and patients may not be symptomatic, which is loss of urine, back pain, too much vaginal pressure. And so 2s we can help to change to 1s, and 1s we can help change to 0s.
Wow. Awesome. So there is hope, and there's hope at any age, correct?
There's hope at any age. Your pelvic floor muscles can be rehabbed at any age, men and women.
Yeah.
And then we have a lot of young teenagers that leak. And so we can assume that they have good pelvic floor strength, but they have poor pressures. They have too much intra-abdominal pressure when they're doing whatever their sport is or whatever they're doing in their life. So, and some people are deconditioned, and they can be 13 and be deconditioned. And sometimes you're sitting all day at their desk or on their phone on Instagram. And so now we're teaching them posture correction, work on your back, a little core strength, and that can improve things. I have a lot of young women who are coming into me and needing, want to put in a tampon. They have pressures from their friends in the summertime to wear a bathing suit and use a tampon, and sometimes they can't because their muscles are too tight. So we're not going to go in and do stretching. We're going to check their core, because usually their core is too weak, which means their pelvic floor has to work overtime.
Yes.
Right?
Compensation.
As a compensation. So we work on all the spinal changes, which we talked about earlier in this video. And then that will then relax the pelvic floor muscles, and they can use a tampon.
Wow. so much, guys, that can be done. Thank you, Lila. I honestly, there are things that you've mentioned that I was not aware of, and I experienced this problem myself, as well as seeing you. And I would just also say, all you need to do is ask your doctor for a prescription.
And it depends upon your state. Like, I don't know if Florida has direct access. Like,
right, that's another point. Yes,
we have direct access for 30 days or 10 visits, whatever comes first. So
right.
you can just kind of go to a PT who specializes in this type of treatment, and they can get the prescription from your doctor, your midwife, your nurse practitioner, your PA, and that can just be your primary care,
right?
Who can help you get some help.
That's, that's a great point. And yes, many states do have direct access, and Florida is one of them. In fact, I think most states do now. Sometimes it's an issue with insurance coverage and that kind of thing. So, obviously case by case, you call the office, because 9 times the office knows what they need to do in order to either, have them get paid or have you get paid for the visit. And sometimes that's the easier path, because doctors can be resistant, or they might want to send you to, somebody who's in their network. Nowadays they have these big networks, and they're reticent about referring out to other people, and the individuals who work at those clinics might not be as skilled as, someone like Lila and other PTs who are in private practice. So that's an important thing to be aware of also.
Right.
That's happening a lot these days, unfortunately.
Yeah. And, just the United States alone is being broken up into health systems. So, sometimes having the ability to just find a practitioner you want to work with is a lot easier than to sometimes navigate in your health system.
Absolutely. I agree 100%. So well, thank you again, Lila. I really appreciate your time. And it was really great to catch up, and what a great education. So thank you so much for taking the time to.
All right, anytime.
Thanks so much.
Thank you so much for joining us today on Step Up with DL Walker. For any information about our guest, it'll be found in the comments box below this video. For more information on how you can recover from injury, restore vitality, and gain resilience from disease and trauma, all in the comfort of your home, click the link on the screen. Until next time, take good care of your body, mind, and spirit. It's the only true home that you really have.